Ankle fractures case discussion. A 40-year-old male presents with a right ankle injury following a fall from a height. He reports significant pain, swelling, and inability to bear weight. Physical examination reveals swelling and tenderness over the lateral and posterior aspects of the ankle with ecchymosis but intact skin. Radiographs reveal a lateral malleolar fracture. A posterior malleolar fracture involving 30% of the articular surface with syndesmosis disruption. The surgeon considers two treatment options for the posterior malleolus and syndesmosis: posterior malleolus fixation versus transsyndesmotic screw fixation. Key considerations. Role of the posterior malleolus. Acts as a posterior buttress to prevent posterior talar translation. Serves as the attachment site for the posterior inferior tibiofibular ligament, essential for syndesmotic stability. Indications for fixation of the posterior malleolus. Involvement of greater than 25 to 30% of the articular surface. 2 mm displacement of the posterior fragment. Syndesmotic instability or widened tibiofibular clear space. Fixation options. Posterior malleolus fixation, achieved via a posterolateral approach. This restores the joint surface and syndesmotic stability indirectly. Transsyndesmotic screw fixation, stabilizes the syndesmosis by directly compressing the tibia and fibula, often used in cases without adequate posterior malleolus fixation. Controversy in management. Recent evidence suggests posterior malleolus fixation may achieve both anatomical reduction of the posterior fragment and syndesmotic stability, potentially obviating the need for a transsyndesmotic screw. Possible Viva questions and answers. What are the biomechanical functions of the posterior malleolus? It prevents posterior talar translation and provides a stable attachment for the posterior inferior tibiofibular ligament, contributing to syndesmotic stability. When should the posterior malleolus be fixed? When it involves greater than 25 to 30% of the articular surface, is displaced greater than 2 mm, or contributes to syndesmotic instability. What are the advantages of posterior malleolus fixation? Restores joint congruency. Indirectly stabilizes the syndesmosis through the posterior inferior tibiofibular ligament. Avoids the need for transsyndesmotic screws in many cases. What are the indications for transsyndesmotic screw fixation? Persistent syndesmotic instability despite adequate posterior malleolus fixation. Absence of a sizable or reparable posterior malleolar fragment. What are the surgical approaches for posterior malleolus fixation? Posterolateral approach, provides direct visualization and access to the posterior malleolus. Anterior to posterior screws, used less frequently due to difficulty achieving anatomic reduction without direct visualization. What are the limitations of transsyndesmotic screws? Risk of screw loosening or breakage. May restrict natural motion of the syndesmosis. Often require removal postoperatively. How is syndesmotic instability assessed intraoperatively? By performing a stress test under fluoroscopy or directly testing tibiofibular stability after fixation of fractures. What complications are associated with inadequate posterior malleolus fixation? Chronic syndesmotic instability, posterior talar subluxation, post-traumatic arthritis, and persistent pain. What recent evidence supports posterior malleolus fixation over syndesmotic screws? Studies have shown that posterior malleolus fixation restores syndesmotic stability by addressing the posterior inferior tibiofibular ligament attachment, reducing the need for additional syndesmotic screws. What post-operative considerations are important after posterior malleolus fixation? Early range of motion exercises while protecting weight bearing to avoid stiffness and promote joint recovery.